In the intensive care unit, the underlying causes of critical illness vary dramatically across diagnoses: sepsis, cardiac arrest, stroke, gastrointestinal obstruction, and many others, each present with distinct pathophysiological mechanisms. Yet despite this diagnostic heterogeneity, most mortality prediction models treat ICU patients as a homogeneous group. This oversimplification can lead to inaccurate risk estimates, especially for rare or complex conditions. To address this gap, we evaluate transfer learning as a powerful strategy for diagnosis-specific mortality prediction using the eICU Collaborative Research Database, a massive, multi-center dataset of over 200,000 ICU admissions. Our goal is clear: to build more accurate, reliable, and clinically useful models that reflect the unique biology of each diagnosis. We compare transfer learning approaches, both generalized linear models, GLM, and XGBoost-based frameworks, against traditional methods, models trained only on diagnosis-specific data, global models trained on pooled data, and the widely used APACHE IVa severity score. The challenge is real. Some diagnoses, like sepsis or cardiac arrest, are well represented in the data, with thousands of patients. But others, such as trauma or gastrointestinal obstruction, have far fewer observations. Training a model on a small cohort leads to unstable estimates and poor generalization. On the other hand, pooling all patients into a single model risks masking diagnosis-specific patterns, introducing bias due to differences in disease mechanisms. The result: models that work well on average but fail in specific clinical contexts. Enter transfer learning, a technique designed precisely for this problem. By leveraging information from data-rich diagnostic groups to improve performance in data-scarce ones, transfer learning allows models to borrow strength across diagnoses while preserving critical target-specific characteristics. In our framework, we treat each diagnosis as a separate target task, and the entire eICU cohort as the source domain. We first train a robust base model on all data, using either a regularized GLM or a powerful XGBoost classifier. Then, for each diagnosis, we fine-tune this model by estimating target-specific adjustments, deviations in feature effects, using penalized logistic regression. This two-step process ensures that the model benefits from population-wide patterns, while adapting to the unique clinical profile of each diagnostic group. We evaluated performance across 4 key dimensions: discrimination, calibration, predictive accuracy under different decision thresholds, and robustness across diverse patient populations. For discrimination, we use the area under the ROC curve, AUROC, and the area under the precision recall curve, AUPRC. For calibration, we employed the Integrated Calibration Index, ICI, and the Breyer score, measures that assess how closely predicted probabilities align with actual outcomes. The results were striking. Across all diagnostic groups, including ARF, CVA, cardiac arrest, and sepsis, transfer learning consistently outperformed both target-only models and global models. In particular, the XGBoost-based transfer learning approach achieved superior discrimination, with AUROC scores surpassing even the source model in several cases. More importantly, transfer learning dramatically improved calibration. While the source model often overestimated risk in rare diagnoses, the transfer learning models produced probabilities that better matched observed mortality rates, critical for clinical decision-making. But perhaps the most insightful finding emerged when we examined decision thresholds. In the eICU dataset, in-hospital mortality rates range from as low as 1.7% in CABG to over 22% in cardiac arrest. Yet the conventional 0.5 cutoff, used universally in binary classification, is poorly suited for low-prevalence outcomes. At this threshold, models sacrifice sensitivity to boost precision, missing many true deaths. Instead, we explored the Youden index, the threshold that maximizes the sum of sensitivity and specificity. This approach, which naturally balances true positive and true negative rates, consistently yielded higher balanced accuracy and F1 scores across all diagnoses. In fact, the Youden cutoff outperformed both 0.5 and the observed prevalence in nearly every case. Why does this matter? Because in the ICU, missing a high-risk patient can be fatal. A model that identifies more true positives, even at the cost of slightly more false alarms, can save lives. The transfer learning framework, by improving calibration and maintaining high performance across varying thresholds, offers a more reliable tool for clinical triage. To further validate these findings, we conducted a simulation study designed to mimic real-world limitations. We generated data with controlled levels of outcome prevalence and signal strength, varying both the degree of heterogeneity between source and target populations and the strength of predictive signals. When baseline discrimination was moderate, meaning the source model wasn't already near optimal, transfer learning delivered clear gains in AUROC and AUPRC. But when discrimination was already strong, improvements diminished, revealing a ceiling effect. This mirrors what we observed in the real data. Once a model is highly accurate, there's less room for transfer learning to help. Yet in low-data, low-signal settings, exactly the context of rare diagnoses, transfer learning shines. This leads to a crucial insight: transfer learning is not a silver bullet. It works best when the source and target domains share enough similarity to allow meaningful knowledge transfer, but differ enough that a one-size-fits-all model fails. In the ICU, where disease mechanisms diverge widely, this balance is delicate but achievable. Looking ahead, our framework is not limited to mortality prediction. When integrated with electronic health records, it can support early warning systems for clinical deterioration, emergency department triage, and prediction of length of stay, readmission, or laboratory trajectories. Future work will focus on external validation across diverse hospitals, regions, and demographic subgroups, essential steps toward real-world deployment. Ultimately, this research advances a new paradigm. Predictive modeling in critical care must be both personalized and scalable. By combining the power of transfer learning with deep clinical understanding, we move closer to a future where every ICU patient, regardless of diagnosis, receives a risk assessment that is not just accurate, but trustworthy, interpretable, and actionable. The path forward is clear. Embrace diagnostic heterogeneity. Build models that learn from the whole, while honoring the individual. And in doing so, we don't just predict mortality, we improve care.